Professor Diederik Bulters is a consultant neurosurgeon at University Hospital Southampton and is one of the UK's leading specialists in vascular conditions of the brain and spine. He performs the largest number of neurovascular operations in the UK each year, including surgery for aneurysms, AVMs, durofistulas, and cavernomas. His professional achievements are extensive. These include President of the British Neurovascular Group, Neurosurgery Lead for NHS England South East, a member of the Society of British Neurosurgical Surgeons Research Committee, and an Associate Editor of the British Journal of Neurosurgery. Professor Bulters, I don't know how you get time to sleep. That's a lot. Alongside his clinical work, Professor Bulters leads major international research on risk prediction and treatment for vascular lesions. And we're very proud to have him serve as our neurosurgical lead at Cavernoma Alliance UK. So Professor Bulters, thank you so much for delivering this webinar. I'm going to put the spotlight on you now.
Thank you for that introduction, Helen. It's great to have the opportunity to talk to people. It's always a bit funny talking for an online webinar, not quite seeing what everybody's thinking, but hopefully I'll keep you all on board. The first thing to point out probably in this talk is, as Helen pointed out, I'm a neurosurgeon and I'm not a geneticist. So although I have knowledge of this area, I'm not necessarily the best person, but I hopefully see the patient perspective on things. And we're going to try and cover what I think are what most people. So we're going to run through from basics and we're going to cover, as say, both from basics to with genetics, you get into quite detailed things as well. And I'll try and cater for what everybody needs, because I suspect there'll be some people joining this really with very little idea what the subject is, just kind of wondering, is it possible my aneurysm runs in the family or not? Through to people who know their aneurysm runs, aneurysm cavernoma runs in their family, with very detailed questions about their specific genetic situation. So I'll try and cover all those as best I can in one talk. But we'll basically build up from what is a familial cavernoma to how do they differ from other types of cavernoma, what subtypes of familial cavernoma are there, do they get treated differently, and I guess one big question that comes up is, should I have genetic testing? So to start up, just with, to be clear what a cavernoma is, the image there I show is just to clarify for people what vessels look like, that you have arteries which pump blood from the heart somewhere, and then they go via a fine network of microscopic blood vessels called capillaries, and then they go to the veins that drain back to the heart. And the relevance of that is that cavernomas are abnormalities of blood vessels, but they form in those very small blood vessels, not in the big blood vessels, and that's quite important for how they behave. And what happens is, for reasons that we sort of only partly understand, those microscopic blood vessels essentially dilate up and create caverns, and that's what you can see in the middle image here, that sort of purple area, and that's the cavernoma, and that's where the name cavernoma comes from. And that's practically what it looks like at surgery. That's one coming out of the brainstem, and you can just sort of see the blackish lump in the base there. And I always think that actually means they look a lot like this, which is a blackberry. But for whatever reason, in sort of common discussion about cavernomas, they get likened to being a raspberry, which is quite what they look like, but they don't tend to look bright red like that. So then, if that's a cavernoma, then a term that you might come across, which is a sporadic cavernoma, and that's basically the opposite of a familial cavernoma. Sporadic means it happens by chance, essentially a one-off. And 4 out of 5 times when you come across cavernomas, it's exactly that. It's a one-off, and you can see in the MRI scan sort of one little blotch. On scan, we often describe them as looking like a little lump of popcorn. And in those cases, essentially, you never see a family history. A familial cavernoma, by contrast, by definition, runs in families. About 1 in 5 cases of cavernoma is like that. But what's really distinguishing is that there's lots of cavernomas, and that can really vary from 3, 5, 10 through to hundreds. And these are generally due to some genetic change, and I say it's handed down through the generations. But it appears on scan varies a lot. So this is a reasonably dramatic looking scan. How many you find can depend a lot on how you do your scans. So using this series as an example from somebody, if you do a standard CT on the left there, you don't necessarily see very much. If you do a relatively standard MRI second from the left there, you start seeing maybe there's a few black blotches. And then as you do more specialist MRI scans towards the right, you suddenly see lots of black blotches, which is essentially specifically looking for iron in the cavernomas. And you suddenly discover there's a lot there. The main relevance of pointing that out is with familial cavernomas, people can get quite fixated on how many do I have and get quite frustrated that they sometimes see different things in different reports. And the reality is when you see a scan like that, you start to realize actually there's so many there, it can be difficult to count. And often they sort of half overlap. And so sometimes it's difficult to say, is that two overlapping ones or is that just one big one? So yeah, just I think that's probably useful for people to realize because I see that quite often cause anxiety that they're not being taken seriously about, is it 5 or 6 that I have? They don't all have to look like that. So you can have far less than that. And actually most are probably far less than that. And you can get a case like this where you've got quite a large single cavernoma in one area. But then when you look sort of on these other scans where you see the arrows pointing totally different area, you have a few small little blotches just by the arrow representing a few other cavernomas. So then I was just going to run through sort of a table where I go through line by line things that are different and the same about sporadic and familial cavernomas. So the obvious thing that we've mentioned is that with familial cavernomas, there's multiple. And if it doesn't run in a family, there's basically a single. And that's a really important distinguishing thing because lots of people have a single cavernoma and they ask, are you sure it doesn't run in my family? If you've got a single cavernoma, it's almost certain it doesn't run in the family. Not that familial cavernomas are necessarily specifically form in the spinal cord, but because you've got lots more, there's more chance that one forms in the spinal cord. And so spinal cavernomas are very rare in general, but they're a bit more frequent in familial cavernomas. And they look like something like this scan. You can see the arrow pointing at a blotch, basically in the big black line running up and down, which is the spinal cord. Sort of quite a technical term, but again, people see it sometimes when they look up, is that standard cavernomas are often associated with something called a developmental venous anomaly, which is essentially a big vein that drains the blood away from them. It doesn't have that much significance other than you see it on scans and you see it in reports. And it does distinguish from familial cavernomas. So familial cavernomas typically don't have a developmental venous anomaly. So if you get a case, somebody like this, where there's a big developmental venous anomaly, which is that big white line that ends essentially like in a network of branches. That's what a developmental venous anomaly looks like. And they have a few cavernomas associated around the brainstem with that. Now, statistically, that should be less likely to be one that runs in a family because of the developmental venous anomaly, but it's not a hard and fast thing. Now, genetics is the obvious difference again. Sporadic cavernomas have no genetic cause, but familial cavernomas very much do. In terms of the age at which you come across them, although cavernomas in general are believed to form early in childhood, for them to give symptoms, it's usually adults for sporadic cavernomas, but in familial cavernomas, they tend to present younger and are more often seen in children. In terms of growth, so a solitary cavernoma, essentially once you reach adulthood, don't change. They can bleed and sort of change in appearance because of small bleeds, but they won't really grow of their own accord, with the exception of whether it's a radiation-induced cavernoma. So there's sort of a separate category of cavernoma, which is cavernomas that form in somebody who've had radiation to their head, and that makes them more predisposed to it. But unless if it's not a familial cavernoma and if there's been no radiation involved, they won't grow. But in familial cavernomas, they can change in size even in adulthood. Similarly, if you have a sporadic cavernoma, you won't develop more once you're an adult. However, if you've got a familial cavernoma, you can throughout life develop additional cavernomas. Then sort of down to the sort of big ones that people ask about, well, what's the bleeding risk? Is it bigger for familial cavernomas? And most of what we can work out is that the cavernomas themselves are not at increased risk of bleeding, but because you've got a lot more, each one individually can still bleed, and therefore cumulatively you have more bleeding risk. And that's sort of the same for the risk of seizures, which is the other main risk with cavernomas. Again, about a 1% per year risk if you have a single cavernoma. But if you've got multiple cavernomas, then there's more chance that one of those irritates the surrounding brain and causes seizures. So that's the broad differences between single cavernomas and multiple or familial cavernomas. Then within familial cavernomas, we know of at least 3 causes for that. So these are acronyms. As I say, they're sort of not exactly friendly to the lay observer. They have all 2 terms. The easy ones are to remember CCM1, standing for cavernoma malformations, and that goes in a 1, 2, and 3. And they represent different genetic changes. Those genetic changes are all essentially to do with the lining of blood vessels and how that heals itself, and that is disturbed somehow in people with cavernomas. The most common type is the CCM1, which accounts for about half of cases, and then about 20% of cases have the type 2, and then the rarest is the type 3. You'll notice that doesn't add up to 100%, that adds up to about 80%. And that is because in about 20% of cases, people have cavernomas that run in the family. They have multiple cavernomas, but there is nothing that can be found on genetic testing. That doesn't mean that there isn't something there, but genetics is complicated and we have a lot of genes and a lot of code, and we simply haven't discovered what those causes are yet. In terms of the severity of those, they essentially are progressively more severe. So the one that really stands out as more different is the type 3, which is associated with a lot more cavernomas than the other 2. And can, sort of some of those images I showed of lots and lots of cavernomas are likely to have been of the type 3. In terms of inheritance, I don't know whether I should go into detail about this. The technical term is they're all inherited in autosomal dominant fashion. That basically means that you have a 50-50 chance of inheriting it. For those interested in sort of seeing what that looks like, if you look at the top row, essentially, if you imagine there being 2 parents, one who's affected and one who's not affected, you essentially have 2 copies of all your genes. And if the person affected, one of the 2 copies has one of those defects, in this case CRIT1, which is the common CCM1 gene, then those split into 2 at the time that eggs and sperm are created, and you randomly give your children either one or the other. And so there's a 50-50 chance that your child will get that gene. So the 50-50 chance you pass on the gene if you have it. That doesn't mean necessarily that they get symptoms. So there's another concept in genetics called penetrance, which is if you've got a gene which is completely penetrant, which is the way people initially think this is how it's going to work, it means if you get the gene, you also get the symptoms. So you have the gene, you also have lots of cavernomas. But actually, not all genes 100% of the time cause something. So you can have what's called reduced penetrance, which means that only some of the people who inherit the gene will get the symptoms, i.e. the cavernomas, and that's represented in the bottom left there. Now that's relevant because the genes have different degrees of penetrance. So if you have the CCM3 gene, it's near 100%. If you have the gene, almost always you're going to sooner or later see cavernomas and symptoms from it. But if you have something like CCM1, that's a bit lower. It's still likely, but it's still 70-80% chance. With genetics, genetic disorders tend to run in certain populations, and that represents that the gene originated in that population. these specific genes, the CCM1 is related to a Hispanic background, particularly around Mexico, a CCM2 around Ashkenazi Jews in the south of America. How relevant that is in the current day in the UK, I'm not sure, but there are clusterings in those populations. Then the sort of things people ask as well, if you have a genetic defect, do I get any other problems? So if you have a single standard, as I would refer to it, cavernoma that's not running in a family, it doesn't come with any other conditions. It's just a single little lesion in your brain. With the genetic causes of familial cavernomas, you can get some other things. So you can get skin lesions, particularly in the CCM1 variant. And they're reported to look like this. I say I'm a neurosurgeon. It's not something I see very often, but it certainly happens. You can also get eye lesions, which essentially don't give any symptoms and are largely picked up by ophthalmology. For what it's worth, if you put a little camera and look in the back of the eye, it looks like that sort of blotch on the back of a sort of orangey background, with the red bits being normal blood vessels. And then in terms of other conditions, you don't really get any other conditions with the CCM1 or 2, but with the CCM3, you can get some degree of cognitive impairment. You can get scoliosis, and you can get some benign types of brain tumors called meningiomas. So that's sort of the nitty-gritty of the different genes. Hopefully that wasn't too heavy for people. So then sort of really moving on to the much more practical questions. So if you've got a familial cavernoma or multiple cavernomas, how does that affect me in terms of is my treatment different? Is my follow-up different? Yeah, does that mean that the advice I see elsewhere for cavernomas, is that relevant for me or not? So I guess the first one of those is really surgery. So, is surgery an option for me if I've got familial cavernomas? Am I more likely to have it, or am I less likely to have it? I guess the short answer is yes, it's still an option for you, and it's not massively changed. There are some reasons why, as a surgeon, you think, well, maybe it's a bit more of a reason to operate on somebody with familial cavernomas, but there are also reasons to possibly shy away. So the reasons why you might sort of say, well, if you've got familial cavernomas, more of a reason to operate. The main one is because, as I said at the beginning, is they can sometimes grow. And so if you see a growing cavernoma, you might say, well, it's getting to a size that this is showing behavior that is likely in the long term to cause you problems. So there are circumstances in which you say maybe more likely to operate than a standard cavernoma. But at the same time, there's the issue that people typically have multiple cavernomas. And therefore, if you operate, you can remove one if you're confident that that's the one causing problems. But you're not going to deal with all the other cavernomas. And I showed you the images at the beginning. In some people, you can't remove them all because there's just way too many. And in many others, even if there's only a few, they're just not in the same location. So an operation to get you to one doesn't get you to the other. So then the question comes up, well, if I can only treat one and I can't treat the others, is it really worth embarking on this? So I'll leave that as the summary is, in the bigger picture, it's roughly the same decision as if you didn't have familial component to it, but there are nuances that may make you more or less likely to want surgery. Then the next question is radiosurgery. Same question. Is there more of a reason to have it or less of a reason? And this, I think, is even less clear. I think the broad advice is that it's still equally valid. In general, I think radiosurgery is less used in the UK, largely because of the uncertainties of quite how effective it is. Practically, it is physically possible to give the radiosurgery, and you can give it to multiple cavernomas, so it's all possible. I guess the sort of more skeptical parts of the doctor community would ask the question whether it is sensible when at the same time we said that people who've had radiation before are at greater risk of forming cavernomas. And while that's fairly commonly not an issue with radiosurgery, if you have a single cavernoma, I guess people don't have the same level of confidence it's not an issue if you have multiple cavernomas and a genetic predisposition to it. And there are basically people with different views on that. And it leaves you again with what I said at the beginning. It probably is still possible, roughly the same as somebody who has a single sporadic cavernoma. Then there's a question about monitoring. And with monitoring, really the mainstay is to do MRI scans. Now, if you have a single cavernoma, I think most clinicians in the UK would recommend not following it up on MRI. And the logic there is that a decision to treat a cavernoma is almost 100% based on, is it giving you symptoms? So, it's a sort of deeply baked into doctors that if somebody is feeling well, don't change it because you can make them worse. And so if you have a scan and it looks a little bit different, should you act on that? And the general feeling is you should only act if the patient is developing symptoms. And that's why for solitary cavernomas, we don't follow up. Now, for familial cavernomas and you have multiple, I think the answer is essentially the same thing, because even though there's multiple cavernomas, we still wouldn't propose treating them unless they have caused some bleeding or caused seizures. I suppose there are some extenuating circumstances where you have particularly large cavernomas, which might show signs of growing. And then you might say, well, we might want to try and treat that before it grows to a size where something like surgery becomes difficult. But I would suggest that that is a small minority of very specific circumstances. And I'm trying to think through the scans I've shown you in so far. I don't think it applies to any other than perhaps the one case with one larger cavernoma and a few smaller ones, where you might say you want to rescan the larger one just to see that it isn't growing to a point where you might want to intervene. So far the message is that largely for most of them, you would actually essentially treat the same as if you had a single one and no family history. The last question then is, what about genetic screening? Should I or should I not have it? So the first thing to say is it's only worth having if you have more than one cavernoma, because if you have one cavernoma, the likelihood of finding anything is negligible. So it's entirely possible. And if you just want to know, it's a perfectly reasonable thing to do. If you look at it from a decision-making standpoint, is the test going to change something I'm going to do, which is the way we tend to look at it medically, then there aren't many reasons for undertaking it. Because if you sit down and think about what are the actions, if I've got a negative test, well, not going to really change anything. So what are the actions if I have a positive test? Well, the obvious thing at that point is to do an MRI scan to look to see if you've got cavernomas. The likelihood is you'll discover cavernomas. But you presumably didn't have symptoms at the start of all this, so they're all going to be asymptomatic cavernomas, which we're going to recommend saying best to leave them alone and only treat them if they become symptomatic. So that's largely the logic why genetic screening doesn't have much advantage in terms of decision making. I fully acknowledge that you may just want to know, but that is a different reason, and that's a very personal reason. So that's the thought process, whether, why there's limited reason for wanting to undertake it. Then I guess you might turn around and say, what are the disadvantages? The reality is there aren't that many disadvantages. I guess there's an element that some people might find it difficult knowing that they, now know that they have multiple cavernomas and have to learn to adjust to more the knowledge of that, because you shouldn't really be adjusting your lifestyle in any way to fit with that, but the knowledge can affect people. Probably the most practical thing is that you can't get around the issue that if when you come to taking out insurance, if they ask you if you have any conditions, you have to disclose that you have a genetic disorder, and that will likely affect your premiums. And that is a very practical, real thing to deal with. So when there's not that much advantage, um, my personal feel is in most circumstances not to screen. And there's one very clear exception to that. And the exception to that is when you come to family planning. And that's because there are options and choices to be made when considering having a family. Sorry, I should have turned my phone off. Bear with me. So yes, there's very real choices to be made when it comes to planning a family. Now, they're very personal decisions how you handle that, but there are good reasons why you might choose to do something to try and prevent passing those genes on to your children. By far and away, the most common option is essentially through a form of IVF, where you have IVF, and before the embryo is implanted, it is genetically tested to see if they have the gene that causes cavernomas, and then simply an embryo is chosen to be implanted that doesn't carry the gene. And I personally think that is a very advantageous thing to do, and think that's a very strong reason to to consider genetic testing. The other ways that you can use it is you can have a normal conception and then have prenatal testing. That's testing in the womb, where a sample is taken through a needle for genetic testing. You can also alternatively pursue donor sperm or eggs, or indeed adopt. But as I say, I think that the first one of those is probably the most common approach. So for me, this is the one main reason for considering genetic testing. But I would say I still advise people I see to do the genetic testing at the time when you're considering having children. And the reason for that is if that's many years away, then we don't know what changes between now and then. And the genetic tests are likely to move on so that we can pick up, for example, that last 20% that currently we miss on a genetic test. It also means that in the intervening years, you don't have anything to declare for your insurance. So that's the advice I give my patients is basically, unless you're considering conceiving, put it on hold. And when you get to that stage, that's the time to do it. And similarly, if you're worried about your children, and a lot of people are like, I'm not really worried about myself, but I want to worry about my children and I want them to be able to know, it's still, I'd say, let your children grow up to the age where they're considering conceiving and then having the whole family tested. That's my personal view on that. So with that, that sort of rounds off, I think, my sort of overview of what I see as the main issues to do with cavernomas. And I guess it's over to the audience for any questions they have about all that.
Thank you very much, Professor Bulters. I always enjoy doing these webinars because every time I learn something new, and I thought it was a very informative talk. We've had a lot of questions come in. I've already got 6 questions which I'm going to put to you. But just for anyone who's not yet asked a question, we have the Q&A. So please do put your questions there, and we'll try and get through as many as we can. So the first question I have for you, how do you know what is a symptom of cavernoma? And this is something we often get on the helpline. People really unsure. How can they tell the difference between a symptom being caused by the cavernoma and one that isn't?
Yeah, and that's not limited just familial cavernomas. Familial cavernomas have a make it more difficult, but for cavernomas in general, it's a problem. So there's no simple test. So it's not like you can say from a scan this is symptomatic or not. I guess a scan can tell you if it's bled or not, which might give you a clue. Um, it is really, it depends on the symptom and it depends on the location of the cavernoma. So how do I explain it? It's putting pieces of puzzle together. So some things like headaches are just very difficult to know. It's like having a puzzle of white pieces that are all squares and you can fit them anywhere and you're not really quite sure. Um, and so headaches is by far and away the one that causes the most difficulty because people have a lot of headaches for non-cavernoma reasons. And probably the majority of headaches that occur in people with cavernomas are unrelated. But there's no doubt that some of the larger ones can cause you headache. And if they cause a bleed, they can cause headache. But you have this issue with cavernomas that you get bleeds of different sizes, and a lot of them are often very small for that reason that I showed at the beginning, that they're of very small blood vessels. And then the question always comes up, well, a small bleed, is it possible that that is causing a headache? And there's no way of unraveling that. When it comes to other types of symptoms, and so the ones that we find easiest to allocate is where there's a dysfunction of the brain that fits with where the cavernoma is. And that's if you get a numbness somewhere. Then if your cavernoma sits exactly in the bit of brain that controls sensation in that area, you tend to say, well, that's going to be related. But equally, sometimes you get people who have numbness, but the cavernoma is just not in a part of the brain that controls sensation, and then it's probably not related. And it's usually trying to put the two bits together, the location of the cavernoma together with what the symptom is.
Thank you very much. And you touched on this, but I'll just read the question out. Where there are multiple cavernomas in different parts of the brain, would an MRI scan show whether any are symptomatic if there was no evidence of the bleed?
Yeah, if there's no evidence of the bleed, then all it can tell you is to say, if you've got a symptom that relates to a particular function and there's a cavernoma in it, it could be related. But it's the flip side. If there's no cavernoma in that bit of the brain, you can be confident it's unrelated.
Oh, thank you. So the next question, and I'm sure this is one that a lot of people are thinking about, is a potential cure for familial cavernomas. So we have a question, is treatment for familial cavernomas on the horizon? Would this be in the form of cavernoma shrinkage, stopping bleeds, or treating the 40 gene, or perhaps both?
Yeah, it depends what you call horizon. So, you know, I don't think there's any treatments on the immediate next 1 to 3, probably 1 to 5 years horizon. Um, Beyond that, there's lots of things that are being looked at, and it really depends on how successful the research in those go. The obvious thing with familial cavernomas, because they're genetically driven, is to look at some genetic solution. When I say some genetic solution, that is either a drug that settles that gene or counters that gene, or a direct treatment to alter that gene. Those are both areas that, in genetics in general, are advancing very fast at the moment, um, and may trickle down to cavernomas, but I don't anticipate that's going to be in less than 10 years. Um, yeah, I don't know if that answers the question.
Oh, it does. Thank you so much. And I'm just going to put the chat in the chat for everybody. So many of you may be aware, but in case not, CAUK is very interested in gene therapy research. We co-funded the UK's very first gene therapy research with Cavernoma Ireland and a philanthropist, and that research is taking place at UCL. And as Professor Bulters said, research takes time. A gene therapy, we're probably looking at about 10 years. Also in America at Duke University, they're currently undertaking gene therapy research as well. So we're working really hard at CAUK to advocate for this because we recognise particularly for familial cavernomas. This is a really important area of research. I'll also put in the chat a link to our new research page, which talks about all the UK research. There's also an excellent page in the US, which our colleagues have about all the international research taking place. So I'll share that shortly. So our next question is, and we talked about spinal cavernomas. When there is a spinal cavernoma present, along with cerebral cavernomas, do they tend to be more active after there has been an initial bleed?
Do the spinal cavernomas, are they more active because one in the brain has been active, you mean, or one way or the other?
Yeah.
Yeah. I think the short answer is no. So I think we consider each individual cavernoma to behave on its own, as it were. So the general concept is if you have a cavernoma that's never bled before, it's very unlikely to bleed again, and it has that sort of what we count as this very rounded off figure of about a 1% chance per year of bleeding. Whereas once they've bled once, they're a lot more likely to bleed again in the future. We run these sort of numbers of anywhere between 10 and 30% will bleed again in the next year or two. But that refers to the one that's bled. And the logic is that the one that's bled, something has burst there and is weak and has tried repairing itself and it's at risk of bursting again. But that doesn't really affect what your other cavernomas are doing. So yeah, I don't think in either direction. If you had a cavernoma in your brain that's bled, I don't think that makes your spinal one more likely to bleed, and vice versa. I think if you had a spinal one that's bled, I don't think it makes one in the brain more likely to bleed.
Thank you. And just to say, we've got 18 questions still for me to go through. So I just want to say to everyone, we're going to do our very best, but apologies, it may be we've got another 20 minutes. We don't get to every question, but just to say we will try and get through as many as we can. So the next one is, I was diagnosed with multiple cavernomas, and my sister has one cavernoma as well. No one in the older generation was scanned. Based on this, do you think I should be evaluated for familial cavernoma and genetic testing?
So first, I distinguish should or is it reasonable? Because there's, as I explained, there's a choice whether you want to be genetically tested. I think the likelihood is that there will be a genetic underlying component. I know that goes against what I said about having a single cavernoma, but they can form over time. So it may be that she doesn't know yet that she has more than one cavernoma. And I don't know what imaging she's had. These are the sort of details you can't get into in a case. And often when you look in more detail at the imaging, as I showed you with the scans, you discover actually there was more than one there in the first place. So I think realistically it is likely that there will be, yeah, I would consider these familial cavernomas and likely to find a genetic cause if you chose to look for that.
Thank you. And then a question from someone who's currently 30 weeks pregnant, and they're asking about the prenatal testing and how would you go about requesting that?
So the prenatal testing, I'm just trying to think practically. So it's something that your obstetricians would practically do the sampling. So it would probably be speaking to your obstetrician, and then they would have to liaise with the genetic service about doing the genetic testing on that.
You. So the next question, somebody's asking, why am I not being monitored, even though I have multiple cavernomas and I've had microbleeds in the past?
Yep. So it comes to what I was saying before that we tend to do scans that are likely or going to make a decision, a fork in the road. Should we do something or should we not do something? And in this context where our main treatment options are surgery or radiosurgery, you basically want to do a scan if you think it's going to lead to a decision between those. Now, unless you are getting symptoms from those bleeds, we wouldn't recommend treating the cavernoma. And therefore, you're better off having a scan when you develop symptoms than just having a routine scan in a year's time when you're not having any symptoms. So that's the advice. Don't monitor just routinely every year or every few years. Do a scan when you develop new symptoms.
The individual who raised this question has just said they are getting some symptoms, they're getting numbness.
Okay. I mean, then it's a little bit difficult for me to gauge without the detail of the scans. But you know, if your doctors, they should look at your scan and see whether you have cavernomas in the area that serve sensation. And then if you are getting new numbness, then I think it would be reasonable to rescan you.
Yeah, so maybe want to go back and to raise that, and then just to add, as we do in all webinars, Professor Bulters can only talk in general because he doesn't have sufficient information to talk about individual cases. But it's really helpful to have these general answers, Professor Bulters. So the next question: do most neurologists avoid doing a brain scan on someone who has hereditary cavernoma if it's asymptomatic? And I think the answer there is yes, isn't it?
I think so. I mean, yeah, it's the doing you're now talking about doing a screening scan rather than doing genetic testing. So if you just have to sort of take a step back and think about it, if you have family members who have cavernomas, the I think the instinct is to say, I'll do a genetic test. But actually, you could just say, well, I'll do a scan of my brain and see if I have multiple cavernomas, and that'll essentially tell me the same thing. Um, the choice to do that scan is very much the same as what I said about the genetic side, and it's basically the same pros and cons. And most of the time, unless you're family planning, there's not that much value in it.
The next question a couple of people have asked, and they're wondering, why does the familial form cause multiple lesions? Why doesn't it just cause one, like the sporadic form?
So the genetic problem is essentially in the ability for the cells that line the inside of your blood vessels to regulate themselves. And that disorder is in all the blood vessels in your brain. And therefore, in any part of any blood vessel of the brain, can things go wrong and develop a cavernoma. And so that's why it can happen anywhere. Whereas what probably happens in a one-off cavernoma is that genetic error gets made in adulthood in a specific set of cells in a specific part of the brain. So only one spot is affected, as opposed to where all your cells in all of your body are affected by the genetic error.
So the next question, you mentioned having benign tumours with cavernomas. I have multiple genetic cavernomas and a glioma in my brainstem, but the doctors won't touch it. I'm on a watch and wait. Could it be that it will never grow? I have been given very little information and I'm wondering whether to get a second opinion.
Yeah, this is definitely where you're at the limit without having the detail. Um, Gliomas are a very diverse set of tumors. And realistically, it's impossible to say how they'll behave without having a little bit of tissue from them to look at under a microscope, which tells you an awful lot. But the problem is that when they're in the brainstem, just getting that little bit of tissue is very risky, and I suspect your clinicians have said that's probably not worth taking the risk, and you're better off just repeating scans serially to see if it's changing or not, and that will probably tell you how it's behaving. Sorry, I can't remember what the actual part of the question was. So
So they was
it was, is it possible that it will stay stable for long periods of time? It's
yeah,
possible, but there's no way of definitively saying that that's going to happen.
yeah. And they've said should they get a second opinion on this?
Really, really hard to say without the details. All I can say is that in general, I can see that if you had a glioma, in the brainstem, most people would not take a biopsy because it's reasonably risky, and they would do repeated scans over time to see whether it's stable or changing.
Thank you. So the next question, HRT for women with cavernoma, can it cause a bleed or any risk? And just as you answer that, I'm going to put a link in the chat because this is a web page that we've recently updated on this.
Yeah, I'd probably follow that guidance more than anything. I don't have any specific knowledge of this area. My own gut feel on these things is there's a lot of these things where there's discussion about does this have an influence or not, and there are weak bits of evidence. But in general, I think the evidence is not strong enough to be able to tell you one thing or the other. And in that circumstance, usually the benefits of whatever it is we're talking about, in this case HRT, outweigh a theoretical risk one way or the other. So yeah, I would consider it a theoretical risk and not something that I would worry about if the HRT is of genuine benefit.
And so we've put the link in the chat, so do have a look at that. And this is an area that CAUK really wants more research on. As Professor Bulters said, there's one study. Until we have more studies, we won't get a definitive answer. And so we're very, very keen to see more studies on this. But if you click on the link, you'll see what research has been undertaken and what our guidance is. So next question. If a brainstem cavernoma has bled, how viable is removal of brainstem cavernoma, and how likely is a brainstem cavernoma to rebleed?
Yeah. Okay. I guess go in reverse order. So the risk of rebleeding is relatively high. That is not necessarily because they are actually physically bleed more, but it's more because they're in a very sensitive part of the brain. And so if you have a cavernoma in, more towards the surface of the brain that's less sensitive, they probably bleed just as often or rebleed just as often. But the thing is, you don't get any symptoms from them. So what's different in the brainstem is they probably bleed just as often, but you are much more likely to get symptoms from it. And therefore, we talk about symptomatic rebleeding as opposed to just rebleeding. And symptomatic rebleeding with a brainstem cavernoma is of the order of 25% in the first 2 years. You have to be slightly cautious with what you mean with that, because that's a whole range of severities of bleed, from things that can be reasonably severe to also things that can be relatively mild and really just give transient symptoms for a short period of time. So I don't want to over scare people with that percentage of 25% that can sound quite threatening. Mm. Then in terms of, I think the question was, is surgery possible in the brainstem? It's certainly possible. Whether it is the right thing for you comes down to really the details of the scan. And the biggest thing is, if you think about the brain, we think about the overall brain having a surface and a deep part. And it's easy to understand that if you're over the surface close to the skull, it's much easier to take a cavernoma out than one that's much deeper inside. But the brainstem is essentially like a little brain at the base, in the base of the brain, and it has a surface as well. Now, if your brainstem cavernoma is on the surface of your brainstem, it is quite viable to remove it. It's still high-risk surgery and very serious surgery, but it's possible and a reasonable thing to do. If it's plumb in the middle of the brainstem, which means that there is a layer of the brainstem that you would have to go through to get to it, then realistically the damage you're going to do doing that is enormous and almost in no case warranted. But it's that very subtle difference, and we're talking about things of a few millimeters here or there that may change it from being viable to not viable.
Thank you for sharing that expertise there. So just to say, we've got just under 10 minutes left, and I've got about 10 questions. So, Professor Bulters, I'll get through as many as I can, and I just want to acknowledge you're going through so many, and that's so helpful. And I know people are really appreciating the information you're sharing. So somebody said they've been told they've got a spinal cavernoma, and they've been told there's no treatment unless fracture to the spine, and they're asking why not prevent. And they're saying they're feeling quite scared living with what they've been told.
Just trying to think about what we mean by fracture of the spine. Are they talking about that surgery would need to go by breaking some of the bones in the spine to get to it?
Read out the exact words, and to the person who's put this question, maybe you could add a little more detail. They said no treatment unless fracture to spine. Why not prevent? Because it's scary to live with that being said.
I presume, listening to that they mean that you wouldn't consider treatment unless you develop symptoms, which is what comes back over and over again, and it's difficult as a patient to get your head around because you want to prevent something that's happened in the future. And when you're sitting at home with your cavernoma, you're just thinking what's going to happen in the future to this cavernoma, and can often really weigh on you, worrying about the possibilities of what may happen in the future. But then when you see your surgeon who sees you and sitting in front of you, and your arms and legs are working normally, and they are focused on what may happen if you have surgery. And with a spinal cavernoma, overwhelmingly, the risk that you worry about is paralyzing somebody. And that is a very real possibility and risk from surgery. And, therefore, most surgeons would say if the cavernoma is not giving you any trouble to this point, it may never give you trouble. Why would you undertake a procedure that has a reasonably high risk of causing serious problems in your arms and legs?
Just to say to everybody, we know how hard it is living with cavernoma, and often people talk about the physical symptoms. We know it can have a real impact on mental health. So in a minute, I'm just going to put in the chat some information we share on that. But if you're a CAUK member and you live in the UK, we do offer counselling. There's no waiting list. You get 4 free sessions online. So please do get in touch if we can support you with that. So the next question is there anything in terms of food or exercise that should be prevented if one has a familial cavernoma? And just to say, I'm going to pop in the chat here a link to a new page we've got on the gut and diet as Professor Bulters answers.
So, I mean, I very strongly advocate that. I appreciate again what Helen said there. The mental part of things can be hard to move on from, but the message from us as clinicians has to be to lead a normal life, and to change as little as possible, or basically nothing. And the more we say that, I think that is the most helpful thing we can do. And therefore, when it comes to things like exercise, there really is no evidence that anything really changes your risk of bleeding from a cavernoma. That means you can do hard physical exercise. It means you can fly. Not that I recommend having a head injury, but there's no evidence that head injuries causes a cavernoma to bleed.
Thank you. So next question, do you ever see cystic elements around a cavernoma that can themselves grow or shrink?
Yes, I actually saw somebody today. So I guess the question is, what are those things? So you do see little cysts form around cavernomas. Most likely, they are essentially areas where there've been small little bits of bleeding, and that creates a little pocket. And then blood initially, when it comes out, sets solid. That's what we call a clot. And then over time, the blood breaks down and dissolves and draws in fluid and turns into just a little fluid, little sac. And so if you have lots of little bleeds, they can essentially turn into lots of fluid-filled spaces, which is what a cyst is.
Thank you. So the next question is on vitamin D. And actually what I'm going to do is just pop into the chat the information we hold on the website on that. And I've shared the link just so that we can get through a few more. So the next question is, I have an AVM and cavernoma. I understand that's rare and I've been sent for genetic tests. Are you aware of what they could find? I was not told what they would be looking for, unfortunately.
Yeah, it is rare. It's not unheard of, but it's rare. We don't know of a specific genetic cause for that, so I don't think they'll be looking for a specific gene. So none of the three genes that I've discussed in my talk are associated with AVMs. Um, I suspect they'll be looking for more general. There are other genes that give disorders of blood vessels more generally, and I think that they'll be, in the absence of knowing what else to look for, will be sort of checking for all those types of genes.
We've just got a couple of minutes left, so I'm just going to pick out a key couple of questions we haven't touched on much. Apologies to everyone whose question we can't get to. So this person is asking, if you have the familial gene, do new cavernomas have the ability to grow anywhere where they've never appeared before, for example, in the spine?
Yeah, so essentially anywhere in what's called the central nervous system, which is the brain and the spinal cord, you can form new ones really throughout life.
Yeah. So next question. My son has CRIT1, which was found after having a bleed at 16 months old, and he had the cavernoma removed. And he's since had more cavernomas form. There are no other family members in either side of the family with this condition. Could this have formed in my son sporadically?
Yeah, and yeah, ultimately that is how these these genetic disorders start. They are essentially at some point, you know, commonly when eggs and sperm are created, that somewhere in the process of reorganization of the DNA, there's something goes wrong, and then therefore a child essentially spontaneously develops a mutation like that.
The next question. I have a CCM2, but I only have one large cavernoma. Could it be that they are in my spine instead?
It is possible. Um, Statistically not likely. So the way we think about it is the brain and the spinal cord are part of the central nervous system, and cavernomas can form anywhere in those, and there's no sort of specific spot they're more or less likely to happen. But if you imagine how big your brain is, and then think about your spinal cord, which is this thin little ribbon that goes down, there's just a lot more brain than there is spinal cord.
Lovely. And then the last question that we're going to ask today. You touched on radiotherapy and how this can cause cavernomas. Could you expand on this?
Yeah, I don't think there's that much we can say other than it's something that we observe that there are people, particularly who've had radiotherapy or radiation treatments when they're young. Um, so particularly for childhood tumors and things like that, that they then later in life can develop cavernomas, and they you can recognize that they appear exactly in the area that the radiation was given, and those behave quite differently to standard cavernomas, um, again, because they grow with time, whereas a standard cavernoma would never do that.
Yeah, and just for those interested in radiation as a cause of cavernoma formation, and Professor Bulters there was talking about childhood cancer treatment, I popped into the chat the new clinical care guidelines produced by IUS sister organisation Alliance to Cure, and they've actually got quite a good section in those guidelines all about this and with reference into the research studies. So if you'd like to read up on it, that is a really good source of information. Professor Bulters, that's just been absolutely fantastic. We've had some amazing comments. People have found this incredibly informative, and you've gone through a huge amount in a very short period of time. Thank you ever so much for speaking with us today. We're incredibly grateful.
Thank you for having me.